So thank you again. As you know, the prognosis of primary T-cell lymphomas remains very poor. Overall, the survival curves are remarkably poorer with respect if we compare with the B-cell lymphomas. And there are some other reasons why the progressively improvements in the treatment of B-cell lymphoma were not equally achieved in the treatment of T-cell lymphomas. In particular, these lymphomas did not show the same benefit from different forms of immunotherapy. In particular, we know that a pan-T-cell depletion is highly toxic for our patients. And there are not tumor-specific antigens targets in primary T-cell lymphomas, or at least in the last years we identified only a few of them. Anyway, during the Lugano meeting, there were some presentations of new strategies, mainly focused on the addition of active drugs to CHOP or similar combinations, in sometimes in a very specific case series. There are some studies focused on the identification of active drugs in patients with relapsed and refractory disease, and the design of trials focused on new forms of immunotherapy, in particular the use of monoclonal antibodies, the bispecific antibodies, and more recently the use of CAR T cells. So if we start with the first one, it's very simple: to add a drug to CHOP in a randomized design to identify some improvement. But the strategy with romidepsin did not produce good results, at least in the first presentation of the study that was published some years ago. In this presentation, after the authors updated the results after a median follow-up of 72 months on these categories of T-cell lymphomas, and in a population mostly including patients with disseminated disease and with extranodal organ involvement. And these are the results. There was a significantly marginal improvement in progression-free survival, and an improvement in the duration of response, but without any change in the survival curves in the overall survival. This study added the contribution of this drug in the T follicular helper phenotype. In this group of lymphomas, the addition of romidepsin was associated with an increase in progression, an improvement in progression-free survival. This was not confirmed in the other types of T-cell lymphomas. Then it should be a specific effect of this drug in this group. The addition of romiplastin was associated with higher toxicity, in particular higher hematological toxicity. Thrombocytopenia is the most commonly related effect, and 2/3 of the patients interrupted the treatment, and 1/3 of the patients need for some dose reduction of romidepsin. And anyway, the main problem is that sometimes the toxicity added for romidepsin obligated the researchers to reduce the dose of CHOP also. Interestingly, when they observed the results in the patient with relapsed disease, or relapsed or refractory disease, they observed a benefit after raw CHOP with the use of allogeneic transplant and better results in the patients who receive subsequently brentuximab vedotin as part of the salvage therapy. The effect of the overall effect of salvage treatment in patients who experienced the relapse or progression after raw CHOP was marginal, with very, very poor results. Then it is important to explore the specific role of some drugs. In the second trial, the drug that was added to CHOP was mogamulizumab. The MOGA is an anti-CCR4 antibody, as explained this morning by Professor Apostoladis. And these are the mechanism of action that was explained very well this morning. In this trial, the patients with an ATL, an aggressive form of ATL of up to 65 years that are not candidates for allogeneic transplant receive, in the case of CCR4 positive on the tumor tissue, receive a combination of mogamulizumab plus CHOP14 for 6 courses with intrathecal chemotherapy as CNS prophylaxis. And then other 2 additional courses of mogamulizumab. The primary endpoint of this study was the 1-year progression-free survival, and the objective of the study was to improve the 1-year progression-free survival up to 31%, starting on the 16% that was published by the Japanese group in the JCOP trial. The sample size, the estimated sample size was 43 patients. These are the characteristics of the patient, as you can see, with a very high median age. The combination was well tolerated. There was not only anecdotal cases of grade 4 toxicity. There were not related deaths. And these are the PFS and OS survival. As you can see, the median progression-free survival was less than 1 year, with a 1-year PFS of 36% and a 1-year overall survival of 66%. Then, when we compare these results with those of the comparator, and the comparator in this randomized trial reported by the Japanese group, the JCOG trial, this was a randomized trial comparing this combination versus CHOP14. This combination produced better results, but was not acceptable due to the toxicity and the inconvenience of strong prophylaxis and GCF treatment. Then the standard of care, the CHOP14, was not changed. When we compared the results of this trial with mogamulizumab versus CHOP14 alone, we can see an improvement in progression-free survival and in complete remission rate in this series. There was also a marginal improvement in the median survival. Then the others concluded this is a good combination, in particular for elderly patients who are not eligible for allogeneic transplant. Respect to the new drugs, one of these is the glidositinib. Glidositinib is a JAK1 inhibitor. The first results of the phase 1 trial were presented at ASCO the last year, and the recommended phase 2 dose is 150 milligrams once daily. In the trial, this patient received this oral treatment for until progressive disease or toxicity, and the complete remission rate, the overall response rate was the primary endpoint. They treated 112 patients with the distribution of T cell subcategories as expected, and most of these patients failed at least a prior line of chemotherapy. These are the results. There was an overall response rate of 44% and a complete remission rate of 24%. And there was not a remarkable difference among the different histology subtypes. However, there were some subgroup of these patients were small, and then it's very difficult to draw definitive conclusions on this. Anyway, this drug was well tolerated. The most common toxicity was hematological, with some cases of non-hematological toxicity, mostly of grade 3. Another interesting drug is lacutamab. Lacutamab was tested in T-cell lymphomas in this study. This is an antibody, an anti-KIR3DL2 antibody that links to the tumor cells and, exert an attractant effect on CD16 cells, NK cells, on the tumor cells. And this marker is expressed in 90% of Sézary syndrome cases in all the tissues assessed, and in close to half of patients with mycosis fungoides. Then these two conditions were considered for this type with a complex design with different cohorts. The first cohorts with Sézary alone, the second cohorts with mycosis fungoides that express the target, the third cohort, the mycosis fungoides that not express these targets, and then finally all the cohorts put it together to achieve the total sample size. The overall response rate was the primary endpoint, and as described by Professor Apollo this morning, it was important the use of the new guidelines for the definition of the response at the lymphnodal involvement. They used the recently reported guidelines proposed by Olsen et al., where all the different components of this disease, the skin, the blood, the nodes, the organs, and the lymph nodes are considered to define the response. And as we will see, using this score, they obtained a higher global response rate. there was not, considering the cohort of mycosis fungoides, there was not a significant difference between the two subgroups, that is, those expressing and not expressing the target. These are the responses. Unfortunately, very low complete remission rate, but with an overall response rate that is close to 30% in this group of patients. When we consider the not expressing group of patients, the results are very similar, with a higher number of stable disease and a few cases of partial response. Anyway, as preliminary results, this antibody, which was well tolerated with only asthenia, arthralgia, and nausea in these patients, may play an important role in the future in the treatment of this disease. And the other two interesting strategies regarding the new forms of immunotherapy in T-cell lymphomas regard, the first one is B-specific, the AFM13, which is used to treat CD30 positive relapsed or refractory T-cell lymphomas. This is a B-specific that tetravalent link on one side the tumor, the CD30 positive tumor cell, on the other side the CD16A positive natural killer cells, and induce the natural killer and cytotoxicity mediated by these cells on the tumor cells. In this phase 2 trial called Redirect, they included different forms of T-cell lymphoma, with the exception, obviously, of extranodal NK T-cell lymphomas and other more indolent forms like large granulate lymphomas. This was the design regarding to the expression of the CD30. 20 patients with an expression of 10% or more were the cohort A, and the others with a lower expression were the cohort B. The primary endpoint was the overall response rate, and the majority of the patients were those with the nodal forms of T-cell lymphomas. Importantly, half of the patients received 3 or more lines of treatment, and 18% of the patients were priorly transplanted. These are the results in terms of tolerability. The drugs were well tolerated. There were not cases of grade 5 toxicity, and the grade 4, 3 and 4 toxicity were only anecdotal cases with some hematological forms of toxicity. Then a well-tolerated drug. In fact, 85% of the patients received the planned dose with a relative dose intensity of 91%, which is an excellent data for a new drug. The overall response rate was 32%, with a complete remission rate of 10% observed in the different forms of T-cell lymphomas. The median duration of response was, and the median progression-free survival was close to 3 months, and the median overall survival was 13 months. Importantly, the response rate, the overall response rate and the complete remission rate was similar both in patients priorly treated with brentuximab vedotin and non-treated with this drug, and there was not a difference in the activity of this drug according to the CD30 expression level. And the last presentation regarding the CAR T cells. In particular, a tumor receptor BC1 targeting CAR T cells in patients with relapsed and refractory lymphoma that expressed this target. This was a homemade CAR T cell focused on this diffusely expressed marker with an interesting to underline that it wasn't a co-stimulator factor, it wasn't 4-1BB. This was the procedure for the patients after leukapheresis. This was maintaining with a bridging therapy in the case that were considered necessary. Then a preconditioning with flu-cy, and then the reinfusion of the disease. This is an important data. 122 patients were screened for the expression of TRBC1, and only 1/3 of these patients, or 1/3 of these lymphomas resulted positive. 19 patients were enrolled. For 20 patients were excluded for these different reasons, the very highly aggressive disease, death, and other forms of kidney failure, and 13 patients were treated. There was two different processes of strategy, in particular to compare the role of frozen or fresh or frozen leukapheresis and different forms of T cell transductions. There was an increase in the dose, in the amount of the cell, but there were not cases of dose limiting toxicity. That is, it was a feasible strategy in these patients. And these are the results in terms of tolerability. There were 12 forms of toxicity, but interestingly, there was a single case of grade 3 CRS. There were not other cases of CRS. There were not major infections and others. Importantly, the CAR T were fastly identified in the lymph nodes assessed in some of these patients. And regarding the response, as you can see, in the patients who received the higher amount of cells, 3 of the 4 patients achieved a complete remission, and in 2 of these patients, the complete remission was maintained for more than 1 year. Then there seems to be an effect, a dose effect phenomena in these cases. But obviously the numbers are still a few. These are the take-home message. I believe that there are some new forms of immunotherapy that deserve more to be investigated further in these types of lymphoma. In particular, some forms of bispecifics and also the CAR T deserve further investigation. We have to take into account that some forms of these new strategies seems to be very specific for some lymphoma T categories and not for the whole population of T-cell lymphomas. And thank you for your attention.